Hey everyone, and welcome. So today, we're going to tackle a pretty serious heart condition with a very long name. Non-ST segment elevation acute coronary syndrome. I know, it's a mouthful. But don't worry, we're going to break down exactly what NSTE-ACS is, what's going on behind the scenes, and how doctors treat it.
So here's the plan. First, we'll get a handle on what this specific type of heart attack really is. Then, we'll dive into the supply problem that's at the very heart of it. After that, we'll put on our detective hats and see how a diagnosis is actually confirmed. And finally, we'll walk through the absolute cornerstones of modern treatment.
All right, let's get right into it. Section 1. What exactly is this type of heart attack we're talking about, and why are we seeing more and more of it?
Okay, so before we can really zoom in on NSTE-ACS, you gotta understand the bigger picture, which is something called acute coronary syndrome, or ACS. Just think of ACS as the big umbrella term for any situation where the blood flow to the heart suddenly gets choked off. It's the official medical term for what most of us just call a heart attack, and yeah, it is always a medical emergency.
Now, NSTEMI-ACS isn't just one thing. It's more like a spectrum. On one end, you have NSTEMI, that's a full-on heart attack that's causing permanent damage to the heart muscle. On the other end, you have unstable angina. It feels the same, it's a serious warning, but the heart muscle isn't permanently damaged yet. So what's the decider? The key piece of evidence is a blood test for a protein called troponin. If those troponin levels are high, it's proof of muscle damage, and the diagnosis is NSTEMI. Now, this is where things get really interesting. This chart shows a major shift that's happening. The rate of another, more dramatic type of heart attack called a STEMI is actually going down, and that's great news. It's largely thanks to things like statins and aspirin. But at the same time, the rate of NSTEMI is actually on the rise. So why is that? Well, it's partly because of an aging population and higher rates of things like obesity and diabetes. But it's also because our diagnostic tools, especially that supersensitive troponin test, are just getting way better at catching it. Okay, so that covers the what. Now let's move on and dig into the why. What's actually happening deep inside the heart's arteries to cause this whole mess? You know, if you boil it all down, NSTE-ACS is really just a classic supply and demand problem. Your heart muscle is a workhorse, and it demands a steady supply of oxygen-rich blood to do its job. But when a blockage in an artery suddenly cuts that supply way back, the demand completely overwhelms what's available. It's like a major city in the middle of a heat wave suddenly losing half its power plants. The grid just can't handle it, and things start to shut down. So what's causing this supply crisis? Well, almost always, it's a blood clot that decides to form right on top of a pre-existing plaque. That's the gunky buildup of fat and cholesterol in the artery wall. And this usually happens in one of three ways. The plaque can crack open and get inflamed, it can crack open without inflammation, or the surface can just kind of erode, exposing the stuff underneath that screams to the body, hey, form a clot here, now. You know, not all plaques are created equal. The ones we're really worried about are called vulnerable plaques. And you can seriously think of them as little ticking time bombs inside your arteries. They tend to have a big, soft, fatty core and are covered by a really thin, fragile cap. It's that flimsy cap that's super prone to breaking and triggering the whole emergency clot-forming cascade. Okay, let's switch gears. A patient shows up in the ER with chest pain. How do doctors actually figure out if it's NSTE-ACS? Well, it's a lot like being a detective. You have to piece together several key clues to solve the case. So, what are these crucial clues? What exactly are doctors looking for to make the call? The first and honestly the most important clue is always the patient's story. Doctors are listening for really specific patterns. Is the chest discomfort severe and happening even when you're just sitting there? Is this a brand new thing? Is it getting worse and more frequent, what they call a crescendo pattern? They're also on the lookout for anginal equivalents, things like sudden shortness of breath or nausea, which can be the main warning sign of a heart attack, especially for women, older folks, and people with diabetes. Clue number 2 comes from the electrocardiogram, or ECG. Think of it like a seismograph for the heart's electrical buzz. Now, in NSTEMI-ACS, it doesn't show that huge dramatic spike called ST elevation, which is exactly why it's called non-ST elevation. Instead, doctors are hunting for more subtle but just as critical signs, like ST segment depression or inverted T waves. These are the electrical footprints that tell them the heart muscle is really struggling for oxygen. And here it is, the final piece of the puzzle, the definitive clue, the blood evidence. We talked about it before, and troponin really is the smoking gun here. This protein normally lives inside heart muscle cells. When those cells get damaged and die, troponin spills out into the bloodstream. A rising level of troponin in the blood confirms that heart muscle has been damaged and a heart attack, an NSTEMI, has occurred. It is worth remembering that other things can cause troponin to rise, so doctors look for a dynamic change, a clear rise or fall, to be sure it's an acute event.
Okay, so once the diagnosis is confirmed, the detective work still isn't quite done, because not all cases of NSTE-ACS are the same. They exist on a wide spectrum of risk. That's where scoring systems like the TIMI and heart scores come in. These are clever tools that pull together all the clues, the patient's story, their age, the ECG, the blood work, to calculate a risk score. This helps the medical team decide, okay, how urgent is this? How aggressive do we need to be right now?
All right, section 4, the cornerstones of treatment. The diagnosis is in. Now what? Well, this is when a really well-orchestrated and powerful medical response kicks into high gear. First things first, you got to stabilize the patient and just take the load off the heart. This means getting them admitted to a specialized cardiac unit for bed rest and round-the-clock ECG monitoring. To help the heart out, they'll start anti-ischemic drugs. Nitrates help open up the blood vessels, and beta blockers slow the heart rate and lower blood pressure. Both of these things basically lower the heart's demand for oxygen, helping to restore that crucial supply-demand balance. But look, dialing back the demand is only half the battle. You could argue the more critical half is attacking the supply problem head-on. And that's why the absolute cornerstone of treating NSTEMI is something called antithrombotic therapy, using powerful drugs to go right after the blood clot that's causing all the trouble. And they do this with a kind of 1-2 punch. The first punch is antiplatelet therapy. These drugs go after the tiny blood cells called platelets that are the first responders in forming clots. Everybody gets aspirin, and then it's combined with a more powerful drug like clopidogrel or ticagrelor. This combo is called dual antiplatelet therapy, or DAPT. But, and this is a huge but, there's always a trade-off. The stronger a drug is at stopping a clot in your heart, the higher the risk of unwanted bleeding somewhere else. It's a critical balancing act for the doctors. The second punch comes from anticoagulants. These are the drugs a lot of people call blood thinners. They work on different parts of the clotting process. While the antiplatelets stop new platelets from sticking, the anticoagulants stop the existing clot from getting any bigger and prevent new ones from starting. And just like with the other meds, there are several options, like heparin or enoxaparin, and doctors choose the right one based on the specific situation. And remember, the treatment isn't just about putting out the immediate fire, it's also about fireproofing the building for the future, and that starts on day 1. That's why high-dose statins are started immediately in the hospital. The goal is to aggressively lower cholesterol and help stabilize any of those other vulnerable plaques that might be lurking. So when you put it all together, what have we got? NSTE-ACS is no doubt a serious medical emergency. But the good news is we have a very clear and effective playbook to deal with it. The goals are straightforward: stabilize the patient right away, use a powerful combo of drugs to attack the clot and protect the heart, and immediately start managing their long-term risk. And that really leads us to a final big picture thought. We have become incredibly good at treating heart attacks once they're already happening. The next great frontier has to be getting better at spotting those vulnerable plaques and preventing them from ever breaking open in the first place. So what's it going to take to shift our focus from emergency treatment to true, powerful prevention?